A 20-year-old boy underwent brain surgery for a brain tumor, followed by radiation therapy. He now presents with increased urination, nocturia, and thirst. What is your provisional diagnosis? Diabetes insipidus, a condition in which patient passes large volume of dilute urine either due to deficiency of ADH or resistance of renal tubules to ADH. Classification and causes. Basically classified into two types, central and nephrogenic. Central is due to damage to pituitary or hypothalamus, whereas nephrogenic is due to damage to renal tubules. Central causes include tumor, apoplexy, Sheehan syndrome, surgery, radiation, head injury, infiltrative diseases like hemochromatosis, and infections like syphilis, TB, meningitis, and encephalitis. Nephrogenic causes include pyelonephritis, lithium, demeclocycline, hypercalcemia, amyloidosis, multiple myeloma, and sickle cell disease. Pathophysiology. Since ADH is not functioning, the water from collecting tubules is not reabsorbed. So more water is lost in urine, causing polyuria and dilute urine. The serum osmolality on the other hand increases, which triggers hypothalamic thirst center, and patient drinks more water, causing polydipsia. Clinical features. It includes polyuria, polydipsia, and signs of dehydration. In patients who cannot drink water, like elderly, ICU patients, and stroke patients, severe hypernatremia can develop, and it results in seizures, lethargy, altered mental state, and eventually coma. It may be associated with other pituitary hormone deficiency. Differential diagnosis. It includes psychogenic polydipsia, diabetes mellitus, and diuretics use. Patient with psychogenic polydipsia presents with polyuria, but this is due to excessive drinking of water. It is associated with psychiatric conditions like schizophrenia, mania, and depression. A water deprivation test confirms the diagnosis. Patient with diabetes mellitus also presents with polyuria and polydipsia, but this is due to glycosuria and hyperglycemia. A blood sugar is done to confirm the diagnosis. Patient with diuretic use also present with polyuria, but there is a history of diuretic use, especially antihypertensive medications. Diagnosis. Urine osmolality, urine sodium concentration, and specific gravity all decreases. Plasma osmolality increases with high or normal sodium concentration. On water deprivation test, urine osmolality remains low in diabetes insipidus, whereas it increases in psychogenic polydipsia. This test distinguishes between the two conditions. Next step is to measure ADH, which is low in central diabetes insipidus but high or normal in nephrogenic diabetes insipidus. To distinguish between central and nephrogenic diabetes insipidus, a desmopressin acetate stimulation test is done, in which urine osmolality increases in central diabetes insipidus, whereas it remains low in nephrogenic diabetes insipidus. Look for central causes by doing a MRI of the brain. Treatment. In central diabetes insipidus, supplement desmopressin acetate, which is a synthetic ADH. It can be given intravenously, intranasally, or orally. In nephrogenic diabetes insipidus, restrict salt, start amiloride or hydrochlorothiazide. Surgery for brain lesion is done in central diabetes insipidus. Now back to the case. The patient most probably is having central diabetes insipidus due to brain surgery and radiation. An ADH stimulation test should be done to confirm the diagnosis, and the patient is treated with ADH supplement.